Our first splinting technique is going to be a rigid splint. So what we have here is possible fracture of the PIP joint in the finger, and it's on the third metacarpal. And so what we're going to do is we're going to take some strips of tape and we're going to rip it in half, an inch and a half in half, getting smaller strips so we can place them for stabilization on each side of the joint. And it's important in a rigid splint, or in any splint for that matter, to splint above and below the joint that is affected. So here we have a household item, otherwise known as the pen. We're going to take the pen and it's going to be on the palmar side of the patient's hand. And I just put the pen cap in the palm so it didn't get in the way of the tape. We place it just along the length of the finger and then into the palm so we can't move the finger at all. Since it's the PIP, we're going to take a strip of that tape and put it proximal to the PIP joint, right around the finger, and then around the pen back up to the finger, locking it in place. The first piece, and then the second piece is going to be right near the DIP joint, and that's to provide stabilization on the joint distal to the PIP, which is the DIP, and so then we're going to just secure the pen there, restricting the patient's movement within that PIP joint in her left third metacarpal joint. So we finish there, and we make sure to check for capillary refill before and after we splint to reinsure that we still have it there. Our next splinting technique is the use of a soft splint, and here we have a possible Jones fracture in the patient's right foot. So we're going to use a pillow that we found around the house and a bathrobe belt to help secure it in the place of an ACE bandage, since we don't have one available. Prior to assessing or splinting the foot, we're going to assess for capillary refill, or otherwise pulse, and we're going to make sure that we're going to stabilize one joint below the affected body part and then one joint above. So in this place we're going to secure the metatarsal distal to the Jones fracture, and then the ankle, and moving up into the tibia and fibula. So we're just going to continue to wrap around the structure, providing a little bit of padding around the fracture site, but nothing that's going to impede it from having too much motion, or also present it to possible re-injury or further injury. So this is just an easy way to get a patient to the hospital if something like this were to happen at your home and you didn't have available materials. So here I just tied on another long sleeve shirt to finish up the wrap and then secured it off. We're going to make sure not to apply too much pressure at the fracture site, which is the base of the foot, or the lateral portion of the foot, and then we're going to have to continue to check capillary refill as we finish, and it's especially important when we finish to make sure that we still have the blood flow there at the patient's toes. Our last splinting technique would be an anatomical splint, and here we have a suspected shoulder pathology in the patient's right shoulder. So we're going to assess capillary refill and pulse in our distal radial pulse in the limb before we start splinting. Here I use the same bathrobe as the previous one to provide a sling type motion, and that would help the patient be able to relax, so they weren't tending to pull up their shoulder into a supine motion. And then I used a t-shirt that we rolled up from the previous injuries to kind of wrap around the body. It forms kind of like a 4S wrap, but without the use of an ACE bandage. This still allows the shoulder to be in a secure, stable position where the patient feels where they can relax their limb, but then also keeps it tight towards the body, and then also allows for the continual check and accessibility to the distal radial pulse and the patient's nails to assess for capillary refill. So in this way it protects the joint, but then also allows it to be stable near the body and reduce the range of motion. So here we have a supine cervical stabilization technique, and right when you approach an athlete, if they are supine and not wearing a helmet, you're going to want to stabilize the skull by grasping the skull beneath the occipital bone and the mandible on each side, maintaining that firm stabilization. And you can use your forearms to help stabilize the side of the head while grasping more towards the base of the patient's neck or the superior part of their shoulders to kind of help this. And then you want to check for signs of breathing and level of consciousness. So you want to do that after you are in a cervical stabilization, because you don't want the patient to move or potentially further the possible injury that they have. And keeping them in cervical stabilization reduces the risk of lacerating the spinal cord or furthering joint or disc herniation, and it just helps maintain the patient's position while you're able to assess the rest of the injury. And it helps if you have another person there to remove equipment if they have equipment on and if it's necessary to do so, and then to check level of consciousness and breathing obstructions, or establishing a new airway using a nasopharyngeal or oropharyngeal adjacent. And then we can continue to talk to the patient this way while maintaining cervical stabilization throughout the entire portion of the evaluation until we get a C-collar available, or we get some blocks on the either side of their head as we spine board them. So it's important to maintain the position, keeping everything in a stable area. And then you also, if you're the person with cervical stabilization, you are the head of the evaluation that's going on. So you help guide the people that are there to assist you, the spine boarding techniques, if that's where the patient needs to be next, and if anything with the equipment needs to be adjusted, that all comes from your direction. In addition to cervical stabilization, you're going to want to move the patient's spine, cervical spine, back into cervical neutral as one of the first assessment pieces you can do if the patient's not resisting the movement, or if it doesn't inflict any pain or reproduction of any of those symptoms as well. And here we have a prone cervical stabilization technique. And so what you do when you approach the patient is you want to position your knee offset from that patient, so when you have to log roll them over or flip them over supine, you're already in line with their cervical stabilization. And this means you also have to reverse your hands. So my right hand is on her right cheek, and then my left hand is cupped underneath her left ear. Same landmarks, occipital bone and the mandible, to provide that stabilization if they don't have a helmet on or any other equipment. Again, you're going to do the same steps as you would in a supine cervical stabilization. You're going to assess for levels of consciousness, airway, breathing, any obstructions that the patient might be experiencing. And then you're going to continue to maintain and monitor those vitals as you prepare the rest of your help or AT staff or physicians or any other person who's there beside you to position the patient in a supine form to further your evaluation. So it's important to not try to force any of the cervical neutral yet until the patient's in a supine position. You just want to maintain that stabilization, and making sure your knee is offset, so when you do the log roll, it becomes easier to just rotate your hands into a position where you're already able to provide that stable and firm ground. And then you can perform any other spine boarding techniques or equipment removal if need be, but this first portion of it allows you to really ensure that the patient won't move if they are unconscious or conscious and face down on the ground.